Hello students, myself Dr. Dhrumil Manek, Assistant Professor from the Department of Prosthodontics and Crown and Bridge, Vinayaka Mission, Shankaracharya Dental College, Salem. So now in this video or in this class we are going to study about a topic which is very important before you start fabricating your or if you are planning for your cast partial denture for your patients. Right, and the topic is mouth preparation in removable partial dentures. So now when I am saying mouth preparation in removable partial dentures, so what we are doing is we are preparing the mouth so that we can give an accurate cast partial denture or an removable partial denture which the patient can use for the daily functional activities like mastication, speech and all other things, right? So before always you go for any prosthetic treatment, there are few requisites which have to be followed before you start making the denture or any kind of prosthesis, and that stage of treatment we call it as pre-prosthetic stage of mouth preparation. So basically in this lecture we are going to mainly study about the pre-prosthetic part of the mouth preparation, and followed by it in the next part it will be taken as a prosthetic part of the mouth preparation, right? So these are my contents. We are going to start from the introduction, definition, various steps in the fabrication of cast partial or removable partial denture, what are the objectives of mouth preparation, the different classifications, and non-prosthodontic management, or we can also call it as pre-prosthetic management of mouth preparation for removable partial denture. So without wasting much time, starting with the introduction, right? So the mouth preparation is a very fundamental process which is very much important before fabricating a removable partial denture, right? So mouth preparation, perhaps more than any other single factor, contributes to the philosophy that the prescribed prosthesis must not only replace what is missing but also preserve the remaining tissues and structure that will enhance the treatment of removable partial denture, right? So when we are saying this, what I mean is our job is not only to replace whatever is missing, we should also look into preserve which can be saved and which might enhance the treatment of our patient, correct? So when we are talking about removable partial dentures, there will be few or several conditions where you can save few structures or teeth and which can enhance or help you in fabricating a better removable or cast partial denture. So that is the whole and sole purpose of this class, and for that we need to have a thorough case history, the knowledge of how to plan the cast partial denture, and ultimately apply that knowledge when we are doing our patients, right? So moving on to the next part, that is definition. So whenever we start any question or a long answer or a short note, what happens is the first thing we write is the contents, and then slowly we move on to the introduction, definition, classification, all those parts, right? So when I am talking definition, there are two definitions given. First is by William McCracken and second is by George Ward Glan. Okay, so what did William McCracken say? Mouth preparation for partial dentures follow in logical sequence after the oral diagnosis and treatment planning. We might say that mouth preparations begins where the treatment planning leaves off. I'll tell again, the mouth preparation begins when the treatment planning leaves off. That means we do the diagnosis, case history, then we plan the treatment. Once our treatment plan is over, then only the mouth preparation stage is going to start. So this was very well given by William L. McCracken. Similarly, even George Ward Glan, he also has given the problems of the dentist in making a removable partial denture are similar to the problems of an architect when he is designing a building, right? Our structure or our job is almost same like an architect. We are going to again make the foundations of the mouth, that is the teeth, through which majority of the functions are carried out. Similarly, the architect is also going to create the foundations and make a building. So the architect must interpret the effect conditions at the building site will have on the building. So what all are present near the building, that is similarly what all is present in and around our oral cavity, that should be understood well, and what will be the effect of those structures when we are giving that prosthesis. So that is very important to understand. So these are the two main definitions You can go with the first one, that is more easier and more practically sound to write it on your paper. Otherwise, the definitions given by glossary of the prosthodontic terms GPT-10 are always a gold standard to write in your examination. Okay, now what are the steps in fabrication of a removable partial denture? In total, there are 6 steps in the fabrication of removable partial denture. First is the diagnosis and treatment planning or treatment of any emergency situations or conditions, then oral surgical, periodontal, surveying of the cast and diagnosis. These are the second part. Third is designing of the RPD. Fourth is mouth preparation. Fifth is fabrication of removable partial denture, and sixth is insertion and periodic recall. So these are the 6 main steps which we follow routinely for each and every case. Now each and every step will be different for different cases. Only the headings are same. What you are doing inside these steps might change from case to case, and that is why we are studying this topic in thorough, right? So what are the objectives of doing mouth preparation in removable partial denture? First thing, to facilitate placement and removal of prosthesis. See, cast partial denture or a removable partial denture. So the name itself is saying that it is a removable prosthesis. So the patient should be easily able to remove and wear the denture, correct? Second, facilitate its efficient physiologic function, right? So what is the physiologic function? Mastication, speech. These are the 2 main physiologic functions which we carry out, right? Swallowing, right? So all those things are the routine things which we do and which are necessary. So with that RPD in the mouth, the patient should be easily and efficiently be able to do all these functions. Then enhance its long-term success. It's not that the patient will wear it for 2 months and then he's going to leave it. Cast partial dentures are a definitive prosthesis which are considered to be for a long period of time. So whenever we are planning such prosthesis, we need to keep in mind the surrounding teeth and the soft tissue which is present. What will be the effect of the cast partial denture on those soft tissues? What will be the force? What will be the dynamics? All these things are very important. Again, to establish a state of health in supporting the contagious tissues, to eliminate interferences or obstruction to the placement, to establish an acceptable occlusal plane and scheme, and to alter the natural tooth form. See, sometimes you might have to alter the natural tooth and then go with an RPD. There are situations like that also. So ultimately all the objectives should be kept in mind well clear, and then proceed with the fabrication of a cast partial denture. Now when I want to classify the mouth preparation procedure, I already told you there are 2 types. One is prosthodontic procedure, second is non-prosthodontic procedure. Prosthodontic procedure includes all prosthetic work, whereas non-prosthodontic or pre-prosthetic procedure includes all other works apart from prostho which are pre-required before you start making the RPD or CPD, that is your cast partial denture, right? So any work or any procedure regarding the department of oral surgery, regarding the department of ortho, regarding the department of perio and endodontics or conservative dentistry. So any work which is required to do should be done first, and then second the prosthodontic procedures will be carried out. So always when you are planning for any kind of prosthesis, first thing you should do is complete all the pre-prosthetic work. Then second thing what you do is do the prosthetic work. So once you have completed your pre-prosthetic work, you will have a great or a clear idea on how to design and plan your prosthesis, so that it goes for a long period of time and the patient can efficiently use it. Okay, so these are the 2 broad headings under which the mouth preparation is classified. As I told, here we are going to study about the pre-prosthetic part and not regarding the prosthetic part. So when I am saying pre-prosthetic part, that means all the works regarding OS, ortho, perio and endo should be carried out, right? So we will see one by one in each branch what are the things or what are the possibilities which you might come across before you think of planning a cast partial denture. So first thing is relief of pain and infection. The teeth are causing pain or discomfort due to caries or any defective restoration, and that should be eliminated first. See, patient is coming with a complaint of pain. You are seeing there are several teeth missing. You cannot directly jump onto giving him a cast partial denture or a removable partial denture. Your first duty as a doctor is to address that problem, that situation first, and then move on to the prosthodontic part, right? Similarly, if there are any large carious lesions which are asymptomatic, the patient is saying I don't have any pain, you just make the RPD or cast partial denture and give. I am not worried about the teeth which is having caries because I don't have any pain. So that doesn't work that way, right? That one teeth which is having caries, if it was sound and natural, proper, then you might have used that as an additional support for your cast partial denture, which might make your processes more efficient. Now when that teeth is carious and you cannot include that in your designing of RPD, that means you have now one teeth which is not going to contribute in the support of your cast partial denture. So always address the emergency or the problems before and then go for the prosthodontic intervention, right? So I think I have made it clear. I'll keep on telling this again and again for the whole lecture. Similarly, there are gingival tissues that should be treated before: gingival abscess, gingival inflammation. Then for that you need to do scaling, root planing, oral profile access, right? An oral hygiene program should be designed for that patient, particularly seeing the requirements based on the clinical findings, right? So you need to be very clear and precise when you are doing all this planning and all those stuffs. So in that case, firstly, carious lesions or any pain and infection, any inflammation, abscess, oral hygiene, everything should be evaluated first, and then you move on to your upcoming parts. Then next is oral surgical preparation. So you have extraction of the teeth if there are teeth which are mobile, grade 1, grade 2, grade 3. So based on the severity of the mobility of the teeth, you need to decide whether you are going to save that teeth or you are going to remove that teeth. Then removal of root stumps and impacted teeth. There might be few teeth which are impacted that might erupt or might cause hindrance in your design of the RPD. So those root stumps are clearly to be extracted, right? That there can be a chance of reinfection again. Then you have maxillary and mandibular tori and bony exostosis, correct? So in that case also you need to remove that tori or exostosis which is present, because that is an elevation or it might cause hindrance in your path of insertion and removal of the cast partial denture. Any sign of cyst and tumors, any hyperplastic tissue, that means the overgrowth of the tissue has to be addressed. Any sharp ridges or knife edge ridge which might cause impingement when the denture is placed. See, when the ridge is sharp and there is no denture, it won't cause much problem. But when the ridge is sharp, the soft tissue is thin, and when the weight comes onto that, that means it is going to cause pain. Then you have alveolar bone augmentation. Okay, if in any area you require the bone augmentation to be done, that has to be considered first. Tissue conditioning, right? So all these things are very important before you start to plan or design your removable partial denture. Then this is the broad description, right? Extractions firstly. So extraction should be planned properly in order according to the treatment regimen. All the blood tests, everything should be carried out before you extract, right? Any extraction which you are doing should not be non-strategic. It should be a strategic extraction. That means you need to have a futuristic vision that if you are going to extract this teeth, all these things are going to happen, and then this is how you are going to design your cast partial denture, right? If you are not having that futuristic vision, then there is no point of going into this path, correct? So you need to be well aware before you extract the teeth. Only you should be aware that I'll remove this teeth will be gone for RCT, this will be gone for restoration, I'm going to do scaling, and then I'm going to go for my cast partial denture. So that clarity should be present before you start designing or planning for your cast partial denture. Similarly, in this X-ray you see it's a molar, only the root fragments are visible. It's an RC treated teeth. I can see a periapical or widening of the PDL, correct? Barely only roots are present. This might not serve any purpose in your RPD. So totally your job is to get this extracted, let the wound heal, and then go on with your procedure of cast partial denture. Similarly, it goes for impacted teeth. See, the tissue might become inflamed over here. There will be lot of food lodgement. This teeth might impinge into the adjacent teeth over here and lead to caries into the adjacent teeth also. So all these things which are present are to be evaluated before you start your cast partial denture, right? One more thing, again, whenever you are extracting the teeth, it is best to just close the tissues and the bone, compress it properly so that the wound heals faster and it is more efficient, right? Then moving on to bony exostosis in tori. Can you see the images? See on the lower left, this bony overgrowth. Again, many bony overgrowths over here. Center of the palate tori, on the lingual side, both the sides tori. So all these things will create hindrance in your placement and removal of RPD. So this has to be evaluated before you start planning. Similarly, see, if you have a tori which is inoperable, that means you are not able to remove that, then you need to bypass that thing and make a design such that it is not affecting your path of insertion or removal. Even that modification can be done, but that cannot be applied in every scenario. I said in the very beginning that every scenario is different and it is going to vary from person to person. So based on the findings and the clinical situation, you need to decide whether you will go for a bypass of that structure or you need to eliminate that structure. Odontogenic cysts and tumors, right? This we have already studied in our oral path. Any cyst or tumor that has to be treated properly, and then and there you cannot directly start with a cast partial denture. You need to address all the surgical removal of the cystic lesion and everything has to be carried out, and then after that only you can go for planning of your prosthesis. Then hyperplastic tissue. When I am saying hyperplastic, plasia means multiplication. That means there is more number of multiplication of cells that is causing an overgrowth of the tissue. So if there are any hyperplastic tissues, any fibrous tissues, any soft flabby ridges, any redundant tissues, any palatal papillomatosis, all those things has to be excised. Surgical excision should be done precisely so that you get an even layer and a structure of tissue over there. Okay. Moreover, it can also be removed by scalpel, curate, electrosurgery or laser. You can use any modes, that is again based on the severity of that lesion. So the mode also will be decided how much and what you want to excise. Then bony spines, see, what you do is you raise the flap, whatever the sharp bony structures are present, you roundden that off and smoothen it. Again you close your flap. So what happens, you get again an even layer of tissue over the bone which will not cause any soft tissue impingement. I even told you about the compressing of the bone and the tissues after you have completed your extraction. That is called as bidigital pressure. With the 2 digits, that is with your 2 fingers, you can just compress it slightly so that there are no chances or occurrences of those bony spines and spicules, right? Or what you can do is at the time of extraction only you can roundden it so that again you don't have to go back in after a month so that you rounded it and again you wait for 10 days. When you are extracting, you can see very clearly that this tissue or this bone area will be sharp and might lead to impingement. Then and there you can roundden it off, right? So all those things are to be practically visualized and analyzed. Then there is something called as alveolar bone augmentation. That means where you want to augment new bone. This is very rarely done in the cases of cast partial dentures, but again see, it's given in the literature so that it has to be discussed. Bone augmentation nowadays is more common in implants, not in your cast partial dentures. We can avoid this step if you want, but again what does this step means, you should be very well knowing, right? So you can take a bone graft from other site and place a bone there so that it creates a new bone formation over there. You get a proper nice well-rounded ridge that has good stability for the denture. So that things also can be done. Conditioning of the abused and irritated tissues, right? So if the patient is already a denture wearer, the tissues are slightly inflamed and they are abused because the previous denture was not so well and fine, which was not up to the mark, and due to that there is inflamed tissues, and the anatomical structures like retromolar pad, incisive papilla, rugae, everything are distorted. Patient is having burning sensation in the cheeks, legs. So all those things are also to be evaluated. So that can be due to ill-fitting denture. All these problems which I told earlier of the abused and irritated tissues can be due to nutritional deficiencies, ill-fitting and poorly constructed removable partial dentures, endocrine imbalances, diabetes, blood dyskaryosis and bruxism. These are the one of the few common causes. There are many more into the list which can be added, but at least you should be able to analyze or remember this. For this I have a mnemonic, so we can make a mnemonic is B square. You can take it as B E N D. Okay, so B stands for blood dyskaryosis and bruxism, endocrine imbalance, nutritional deficiencies and diabetes, and lastly I for ill-fitting dentures. So that also can be remembered in this way. So at least these 6 if you have in mind, you have a good content for your theory answer. Similarly, there are periodontal problems also. This was all about the oral surgical problems. Now we have periodontal problems. Why do we need to address periodontal problems? Because again there might be chances of an atraumatic occlusal relationship. The occlusal relationship might not cause any trauma, but again that might not be favorable for your cast partial denture. So you need to correct that. Any factors which are causing periodontal disease, bleeding on probing, pockets, right, gingival abscess, gingival inflammation. So ultimately your periodontal structures of the abutment teeth, because you are going to place clasp on few teeth, you are going to place occlusal rest, cingulum rest on few teeth, and you are going to also place major connector, minor connector, all those things, right? So when in these cases if your abutment teeth is not fine, or the foundation of your abutment teeth, that is your periodontal ligament structures are not healthy and sound, ultimately eventually in future if something happens to that abutment teeth where you have placed the clasp, that starts becoming mobile and ultimately goes for an extraction. So your whole effort of designing the cast partial denture is of no use, right? It goes to waste. Again the patient has to redesign, or you need to apply some tricks and tactics to modify and adjust that same cast partial denture, but ultimately it won't be as perfect as the new one, right? So all those issues like periodontal pocket, gingival inflammation, mobilities, calculus, debris, all those things should be analyzed first and then go on for deciding the therapy. So advantages is what? You can remove all the periodontal disease which are a primary factor for tooth loss. Okay, it can create a better environment. The oral cavity environment will be more healthy when you have treated all such problems, and then you can also see the response of the teeth to the therapy, the periodontal therapy which you are giving. So you can also evaluate the prognosis. Suppose you treated and the response is good, that means the long term prognosis of your cast partial denture also will be directly good only, because these both are directly proportional. See, pre-prosthetic procedures are directly proportional to your cast partial denture, CPD, that is the prognosis of the CPD. Okay, so these are directly proportional. The well or the quality with which you have done the pre-prosthetic surgery will decide your foundation and the overall prognosis of your cast partial denture. So there are various periodontal diagnoses and the diseases. Pocket depth you can measure bleeding on probing. This is something basic which we have been doing from our third year BDS, right? Then you can also take dental radiographs, OPGs, bite wing radiographs to see the amount of bone loss, what is the level of bone, how much is the support of the bone, if there is any widening in the PDL, any periapical lesion, if it is caries, till what extent the caries is present. So all those things can be checked with the help of a radiograph, right? Again, the mobility test, grade 1, grade 2 and grade 3. So you also need to evaluate how much is the mobility, and based on that you need to take a call whether to save that teeth. If to save that teeth, how to save that teeth. Okay, if you have saved the teeth, till what extent you can use it as a support for your cast partial denture. So there will be 3 stages in periodontal therapy. First is initial disease control, definitive and recall and maintenance. So firstly we'll address the disease, then you go for a definitive periodontal therapy, and then recall and maintenance. So in the initial disease control therapy, what you do is you give oral hygiene instructions, you do scaling and root planing, you can do a deep curettage scaling also. If there is any overhanging restoration, if there is any area of periodontal pocket and all those things, local irritating factors can also be eliminated. Then moving on to the more definitive part, where you can splint the teeth, you can do gross occlusal correction so that there is no trauma from occlusion, you can give a temporary splint, right? You can also give a removable splint. So all those things can also be done if required. Again, here you can go for gingivectomy. If the gingival overgrowth is more, you can go for gingivectomy, periodontal flap surgeries and mucogingival surgical procedures. Then next will is gingivectomy. Gingivectomy, what you do, you take out some amount of the gingival tissues so that you increase the health of the tissues over there and also make it ideal for restoring with a cast partial denture. You can also go for a flap surgery if there are any periodontal pockets present, or recession, all those things. For recession you have mucogingival surgeries. Then you have guided tissue regeneration, where what you do, guided tissue generation is defined as the procedures that attempt the regeneration of periodontal. So sometimes the periodontal structures might have got infected and they have slowly resorbed or they have been eliminated. So now you need to restore the periodontal structures partly, not the whole one. So in that case you can go for an osseous graft, resorbable membrane. It is mainly for 2-sided or 2-walled or a 3-walled defect and for furcation involvement. So to an extent there are chances you can save the teeth and again rehabilitate it such that it can be used as a additional support for your cast partial denture. Then you have periodontal plastic surgeries, where you can do deepening of the vestibule, any osseous deformities, any elimination of pockets, create any adequate zone of attached gingiva, any root coverage procedures, and also relief of abnormal frenal and muscle attachment. So these are very rarely done in the treatment of cast partial denture, right? But still, as I am saying, given in the literature, so has to be discussed. So what all you can do in periodontal plastic surgery can be included in the objectives of this heading. Then lastly, recall and maintenance. So always once you have done your treatment, recall, maintenance, follow-up is one of the very important part, right? So you need to be very sure and you need to verify what is the status of your patient. Just giving the denture and finishing the case doesn't complete your job. Your job is to take the case till the end so that if the patient is still having any problem, you can evaluate and make it more better. You should always follow up and recall your cases so that you can see how your work is acting. Just that the patient is not calling you or not informing you, that doesn't mean he is fine. He might have shifted to some other dentist also. So that is also one more scenario. Orthodontic considerations, again very less or very rarely seen, not at all seen nowadays. Okay, so if you want to reduce the need of prosthetic teeth, you can do position the teeth according to the natural prosthetic placement, create a sufficient vertical height, allow sufficient occlusal guidance for your natural teeth. Lastly, endodontic treatment, where you have any pulpal involvement, that is any dental caries which is close to the pulp, has reached to the pulp, any periapical pathology. So for all that you need root canal treatment, indirect pulp capping, direct pulp capping, restorations, all those things. Followed by you can go with the crown, inlay, onlay restorations, right? So endodontic and restorative therapy is also the last and the integral part. And then finally, once you are done with all the evaluation of different procedures and the problems, then based on the present clinical situation, you will go for a prosthetic mouth preparation, which will be the next counterpart of this topic. So I hope you guys have understood all the points clearly. If you guys have any doubt, you can directly put it in the comment box, or you can come to the department and directly interact with me for that. And thank you so much for being patient and listening to my class.